Thanks very much, Keith. It is my privilege and honor to present to you the Hokusai VTE study results on behalf of the Hokusai investigators. Some people ask whether this is an acronym. No, I'm just too stupid to remember these long titles, and we thought a beautiful name is something to remember. And probably everybody knows Hokusai, because as you can see, this is his famous wave. I've imagined that at some stage in the conduct of the study, we felt as a steering committee to be in one of those little boats there, but we managed to complete the study as planned. This study compared the standard treatment of venous thromboembolism being low molecular weight heparin followed by vitamin K antagonist with low molecular weight heparin and edoxaban. Edoxaban is the 10A inhibitor, number 3 on the arena. And so what we did in this study is took patients with deep vein thrombosis, pulmonary embolism, or both, and randomized them to the standard treatment, or, as I mentioned, low molecular weight heparin, followed by edoxaban given in a fixed dose of 60 milligram. The dose was reduced to 30 milligram in individuals with a low body weight and creatinine clearance between 30 and 50. Let me just jump, because I only have 5 slides, is to the baseline characteristics. And as you can see here, there were more than 4,000 patients in each of the arms. As you can see, the population, the mean age, as you can see, is actually around 57, which is quite standard for venous thromboembolism studies. We aimed to have 60% of the patients to come into the study with pulmonary embolism, and as you can see, that was achieved. In the area of venous thromboembolism, we talk about provoked, if we understand how the venous thrombosis came about after surgery or a period of immobilization, or unprovoked. It's that group that was 66%, about 2/3 of the patients in this particular study. The dose adaptation, as you see there, the 30 milligram, was necessary in about 17–18% of patients. Let me then jump to the result. One thing I'd like to tell you, what we have done in this study on purpose is really try to invite colleagues to put in the full spectrum of patients with venous thrombosis and pulmonary embolism. And one of the discussions in the area is the group with right ventricular dysfunction. That are clots in the lungs where the right ventricle really is in trouble of pumping the blood around. And that's what we call right ventricular dysfunction. I'm more than happy to give you details if necessary. And here we set out to show non-inferiority for efficacy. And this is sometimes confusing. But you have to realize that the standard treatment of low molecular weight heparin vitamin K has a relative efficacy of 90%. Very different from warfarin or vitamin K antagonists in the setting of atrial fibrillation, where it's only 60%. So we never aimed of showing a better efficacy. We would be very, very pleased to see non-inferiority. And if you look at the upper line, as you can see, 130 recurrences and 146 in the standard treatment, a hazard ratio of 0.89, meeting our criteria for non-inferior easily. That was set at 1.5, and you can appreciate the upper confidence interval is 1.13, so clearly much below what we said. This is even true for the patients with separate DVT and PE. This analysis was following patients all the way out to 12 months, regardless of duration. If you do the standard approach, the on-treatment analysis, the data are there, and they are in the same direction. And they also meet the criteria for non-inferiority. But here is the most interesting observation in this particular study, as far as I'm concerned. And this is this subgroup of what we call a severe PE, which is about 35% of all patients. And as you see on the right side, the warfarin, there are 30 recurrent events, 6.2%. While with the low molecular weight heparin edoxaban, as you can see, 3.3%. And so in this a priori defined subgroup, we actually do observe a hazard ratio of 0.52, which is also statistically significant. But the message here is that these patients that receive low molecular weight heparin and edoxaban and have a severe PE are really better off. We set out to show superiority for safety, taking the first major or the first clinically relevant non-major bleeding episode. And you can see in this slide 3.5 over 10, 8.5 over 10.3, which is a hazard ratio 0.81, and that met our criteria for superiority. It's quite interesting, and I think something we start to realize both in the field of venous thrombosis as well as in AF. We are used to type of bleeding with warfarin, but the type of bleeds with these new oral anticoagulants are really different. Let me just point out to you, the fatal bleeds 2 over 10, less intracranial bleeds, as you see, 0 out of 6. But if you go to the non-fatal intracranials, as you can see, 5 over 12. And the message there is less intracranial bleeding and it's less retroperitoneal bleeding. So therefore, let me just conclude, dear colleagues. The regimen tested in the Hokusai VTE, you don't pronounce the U if you talk to somebody Japanese, Hokusai, is non-inferior to the standard therapy of preventing recurrent VTE. There's a consistent efficacy in the subgroups of DVT and PE. There is, we believe, a clinically significant excuse me, reduction in recurrent VTE in those with right ventricular dysfunction. We looked at other definitions of right ventricular dysfunction using the diameters or the dimensions of the right and left ventricle, and we got exactly the same results. There is less clinically relevant bleeding, consistent effect over TTR I've not shown you, and the dose adaptation was effective and safer. With that, thanks for your attention.
Okay. Harry, thank you for this important study, the Hokusai study.
Correct.
I've learned. And it's now open for discussion. Please.
Hi, I'm Peggy Peck with MedPage today. So this is, as you mentioned, is the third agent that we're looking at in this particular class. And it seems to me from the presentation and from your emphasis that you're suggesting that this might have a slight edge in those really in the patients with more severe disease. Is that what you're saying?
Absolutely correct. One of the concerns that has been raised with some of the other studies is that physicians and investigators were a little reluctant not to use low molecular weight heparin, and therefore, possibly, we are looking into that, we're not happy to include large clot. In this study, if you go by the definition of the pro-BNP, which we used, or the dimension, it's about 30 to 35% are large clots. It's exactly in that group where I think the novel observation is.
Okay, and then just on follow the trial design with this run in everyone being on the low molecular weight heparin prior to an oral agent.
Correct.
Do you believe that replicates clinical treatment more? You know, is that?
I think what we were about to witness is say we can do without low molecular weight heparin, because these agents that were tested, and I was responsible for one of those studies, the Einstein PE study, and I think the conclusion we had from those studies is we could leave out low molecular weight heparin, we could do it with a single drug strategy. I think with the results here, we need to sit down and discuss that probably that's not completely true. There are patients, and actually maybe actually be a large group, that you better give a few days of low molecular weight heparin.
Okay. Next questions. You've silenced everybody, but I have a question.
Good, of course.
What you didn't show us is the design, and one arm has an overlap between the warfarin and the low molecular weight heparin,
Correct.
whereas the edoxaban doesn't. Has this biased your study to have more bleeding in the warfarin arm?
Thanks very much.
I'm going to ask tough questions.
I look forward to tough questions. I've been sitting on these data for weeks, not allowed to talk about it.
Yeah.
No, but you're absolutely right, Keith. The standard treatment is to give low molecular weight heparin. And because warfarin takes about 4 to 5 days, you do start them at the same time. And you only stop your low molecular weight heparin when the warfarin is in the therapeutic range. So that's the standard treatment. And that overlap, probably what we are learning, is necessary because of the dynamics of the kinetics of the drugs. In the edoxaban arm, it was low molecular weight heparin, and a couple of hours after low molecular weight heparin, the edoxaban started. Bleeding, of course, was counted from 0.0.
Yeah.
So all the bleeds that occurred during low molecular weight heparin, where you're not even have given edoxaban, of course, are in the edoxaban group. But this overlap is necessary with warfarin.
And very interesting findings with the reduction in intracerebral bleeding consistent with the other studies, suggesting that there's some hazard with warfarin?
I think the most interesting observation, Keith, because we now have 4 VTE studies and we have a number of large AF studies. They all consistently show that with these new agents, there is less intracranial. And there actually is a very nice biological explanation. And that is, if you use warfarin, your factor 7 may actually go so low that particularly in the brain and in the retroperitoneal space, you do not have enough factor 7. You have abundance of tissue factor, but if you don't have factor 7, coagulation will not begin. And I think there is some experimental evidence from a number of labs that with the warfarin, we have come to accept these type of bleeds. But it may very well be that with these new drugs, that is going to be significantly better. There have been meta-analysis in AF. There is one meta-analysis underway in VT, but they show exactly the same thing.
Great, great. Any other questions? Okay, so Harry's going to be here after for further questions.
We go on with the next presentation, the towel study. It's a pleasure to introduce.